moderators, panelists, learned audience. What we do a nice PCI. We want our patients to come back to us again, not to go to one of our colleagues. But what we fear that the recurrence of new symptoms. Whenever the patient comes with a post-PCI angina, we surely miss a heartbeat. So it is very important. The PCI follow-up starts usually 1 week after the discharge. Sometimes it is delayed. These are the 3 aspects. One of the, whenever the patient is coming, it's usually an outpatient follow-up. The history, physical examination, we do some tests, and these are the non-invasive tests, and in some cases we have to go for a repeat coronary imaging. What are the goals of follow-up? To make the patient feel good with a good quality of life, to reduce the frequency of angina, to increase the quality of life, and prevent recurrence of acute coronary syndrome, heart failure, and sudden cardiac death. These are the goals of follow-up. The follow-up is sometimes we do a solo follow-up. In our country, the multidisciplinary follow-up is a rarity. Particularly, we forget about the cardiac rehabilitation. So I think the follow-up should be very meticulous. Nowadays, in the COVID era, we fail to auscultate the patient as well. And a few days back, 2 to 3 days back, I found a patient in my OPD. He has a significant aortic stenosis. But the treating physician, who is a professor of cardiology, he didn't auscultate the patient and totally missed the diagnosis. So we don't do the follow-up with a non-touch technique. So even if it takes time, the follow-up should be meticulous. The first thing, we need to see the puncture site whenever the patient comes. Particularly, it is very important when there is a femoral puncture. Where there is a femoral puncture, there is sometimes some discomfort, some induration, and the patient should be instructed, particularly the patient praying on a Janamaz. We advise the patient not to pray for at least 1 or 2 weeks. And squatting in the toilet is a very preferred mode of squatting in our country. So we should avoid, instruct the patients, please avoid. And nowadays we are switching towards the radial more and more. When the radial puncture, we tell the patient not to carry weight with the hand where the intervention has been done, and not to do cycling, and while praying, don't to flex the wrist. That is very important. What involved the physical examination is the cardiac murmur. The patient might have a murmur before, it might be reduced, or a new murmur can appear. The pericardial rub, sometimes due to pericarditis, the pulmonary edema, bronchospasm, the bleeding hematoma, bleeding site hematoma, aneurysm, AV fistula. Don't forget to auscultate the puncture site, even it is on the radial, because we have seen that the radial site can have AV fistula as well. And the bleeding, we are using the dual antiplatelets sometimes along with some NOAC and other things which can lead to bleeding. And sudden drop of hemoglobin should alert us that the patient is bleeding from somewhere, and that might lead to recurrence of symptoms. And a 12-lead ECG, and don't forget to compare with the post-discharge ECG, pre-discharge ECG, sorry. And we do some laboratory tests, complete blood count, of which the hemoglobin is very important, and thrombocytopenia, because we are, as Dr. Professor Khaled has said, we are using lot of antiplatelet drugs, and among them, clopidogrel is very notorious for causing thrombocytopenia. So if we find thrombocytopenia, we should alert the patient, and we may change the, we advise for follow-up, they come back 7 days, 15 days time, and if necessary, we can change the clopidogrel. And also, liver function test, the ALT, we are giving high-dose statin. So ALT rise more than 3-fold of baseline should alert us to reduce the dose or change to a more liver-friendly agent like ezetimibe. And creatinine, contrast nephropathy, very important. So we should wait for at least 48 hours to get an evidence of contrast nephropathy. So, and the CPK, if the patient complains of aches and pains in the body, we should not refrain from checking ALT. The 10-fold rise definitely indicates some form of myositis or rhabdomyolysis. And we should tell the patient you should stick to the dual antiplatelet regime unless interrupted by your physician. What is the next follow-up? Actually, 3 to 6 months or when symptomatic, and endurance level, functional. This is the subsequent follow-up. Very important is the family and sexual life of the patient. The patient and the physician both are reluctant to discuss these things. And the occupational activity is also very important. We should check the occupation. And particularly if it is a high-risk occupation, the patient should be more and more cautious, and the physician should be more supportive to the patients. And enrollment in a cardiac rehab program is very helpful. This is a very common scenario. After a percutaneous coronary intervention, the patient continues to suffer from sexual inhibition, and they want the physician to prescribe some medications to overcome this problem. But we are prescribing the nitrates as well, so it is very difficult sometimes to prescribe both. And as usual, the spouse is sometimes very skeptical. They are not very convinced that this symptoms is going to change very much with medications. So here he can say that the physician can only heal the sick, cannot raise the dead. If it is dead from previously, it is unlikely to change. And there are some, the reverse scenario is sometimes very true. The patient has got a lot of expectation from the PCI. So he sometimes expects a thing like this, a myth versus reality. But we should tell the patient that don't expect too much from the PCI. The important, very important thing is the cessation of tobacco, particularly smoked tobacco, chewed tobacco, and the electronic cigarettes. The aerobic exercise, we should advise the patient, do exercise within your cardiac reserve. Proper nutrition in context of good glycemic control and good lipid profile. As Professor Majumder sir has emphasized the need of a good lipid profile. The medications, the optimization of medication like antihypertensive, antidiabetics, heart failure medication, antiarrhythmics should be optimized, and we should be aware of the drug interactions. And the patient behavioral change, the patient should be encouraged. The stress test, not proven benefit. Stress ECG, if they have change in symptoms, which has become worsened after PCI, and patient who cannot do exercise, we can advise for a dobutamine stress echo or a stress radionuclide imaging. It is, can be the stress MRI or SPECT. CT angiogram is a very controversial tool, particularly after PCI, to detect post-stent restenosis. but it can be done very effectively after CABG. And more than 50, only half of the stenosis are hemodynamically significant, and the inducible ischemia is important. Routine CT is not indicated because of the high radiation and contrast load. Relux CAG, class 3 and 4 angina warrants a relux CAG, and when there is a clear evidence that the patient's symptom might be involved, there might be new stenosis elsewhere or instant stenosis, we can advise for a relux CAG. And atypical symptoms, the non-invasive study are done first, and if they indicate a high risk, we go for diagnostic cardiac catheterization. It was previously that after 6 months after a complicated PCI, we used to do a routine CAG, but it is not done nowadays, particularly in the left main bifurcation, long stents or something like that. So it is it should be the choice of investigation should be driven by the symptoms of the patient. These are the high-risk patients on non-invasive testing who has ST segment elevation during ETT, low ejection fraction, wall motion in more than 2 segments after on a dobutamine stress echo, the stress-induced perfusion defect, stress perfusion defect on MRI. These are the patients who are likely to face problem during follow-up, like the patient with LVEF, reduced multiple diseased vessels, proximal stenosis, survivors of cardiac death, diabetes, suboptimal result in previous intervention, silent myocardial ischemia, use of phosphodiesterase inhibitor, and patients with high-risk profession like pilots, drivers of commercial vehicle because of the stress of the occupation. Stenosis is an Achilles heel of coronary intervention. It is defined as more than 50% diameter reduction in a previously treated segment, and we can identify by angiogram as well as quantitative coronary angiography, IVUS or FFR. And angiographic 6 months restenosis rate in bare metal stent is about 1/3, and in drug-eluting stent it is less than 5% nowadays, apart from the complicated anatomical situations. This is due to caused by the migration, proliferation of smooth muscles, platelet, thrombus, elastic recoil, and many other factors. And less than half of all patients with angiographically documented stenosis, they develop symptoms in 1 year. And clinically relevant stenosis is exercise-induced angina, unstable angina, and myocardial infarction, which can affect about 5 to 10% of the patients. These are the patients who are likely to fare badly. The patient with STEMI, ACS, diabetes, multivessel disease, unprotected left main, bypass graft stenting, total stent length of more than 40 millimeter, and intervention in a small caliber vessel. Stent thrombosis is another Achilles heel of coronary intervention. It is patient have new onset angina, dyspnea, ECG change, and elevated biomarkers. The probable stent thrombosis, any unexplained death 30 days after stent implantation, myocardial infarction in the territory of the implanted stent without angiographic demonstration of thrombus, possible stent thrombosis, unexplained death more than 30 days, and this is the classification. The acute stent thrombosis up to 1 day, 1 day to 1 month subacute, more than 1 month late, and more than 1 year late, very late stent thrombosis. The incidence is less than 1%, but it carries high morbidity and mortality. So in conclusion, we want to say that doing a PCI successfully is not the end of the story. We want our patients to be symptom-free in long term. That is the goal, and we all want to achieve that goal. And Thank you for your patient hearing. Thank you very much.